Hello everyone. Today we will discuss about the recent GINA guidelines for asthma management. So the key change is that SABA only therapy is completely outdated now. So it is no longer recommended to use SABA only. So the new standard is to follow inhaled corticosteroids for all individuals having asthma, irrespective of the severity. Why this particular change? Because inhaled corticosteroids will reduce exacerbations, hospitalizations, and asthma related mortality. Whereas if we prefer SABA only treatment, it has shown that it will paradoxically increase the mortality. The core principles in GINA are achieve asthma control and minimize future risk, use lowest possible dose of inhaled corticosteroids that controls symptoms, and regular review. For example, we have to keep on assessing inhaler technique, whether they are using it in the right way or not. Adherence to the devices and medications and regular follow-ups are very important, and treat modifiable risk factors as well. And during follow-up, it is always important to step up the therapy if required, if the disease is uncontrolled. Also to step down if the disease is well controlled for minimum of 3 months. So remember, it is not like a one-time therapy. We have to assess the individual's symptoms control at regular intervals, and accordingly we need to readjust the therapy. Just a recall about the pharmacotherapy which is used in the management of asthma are: first line or the most important one is inhaled corticosteroids, which is considered as the backbone of asthma management. For example, budesonide, fluticasone or beclomethasone. Then LABA, long-acting beta agonists. These are the enhancers. The examples are formoterol and salmeterol. Then comes long-acting muscarinic antagonists. So these are the add-on therapy when managing bronchial asthma. Example will be tiotropium bromide. Then SABA, short-acting beta agonist. It is just indicated as the rescue agent in some of the particular conditions. For example, exercise-induced asthma, where we will suggest the individual to utilize SABA prior to exercise. So the example for this is salbutamol. So these are the examples which we commonly utilize in asthma management. And in recent guidelines, the major focus is given to MART, that is maintenance and reliever therapy. In short, this is the combination therapy. That is, for maintenance, we will utilize inhaled corticosteroids, and as reliever, we will make use of long-acting beta agonist, that is formoterol. So this is the only long-acting beta agonist used as reliever in this particular strategy. So it is nothing but formoterol. So combined together, this will become the MART therapy. In the sense, when we combined both of these medications in the single inhaler, the patient will be using this particular device as maintenance therapy, daily dosages, as well as reliever whenever required. That's why GINA considers MART, that is the combination of inhaled corticosteroids and formoterol, as the best strategy for asthma management. Now we can discuss about the disease per se. First we have to classify the disease into mild, moderate and severe. So how to decide the severity? We consider it as mild if the symptoms are less than or equal to just 2 days per week, and night symptoms will be less than 2 per month, and there is no limitation to the activity. So such individuals are considered under mild severity. Coming to moderate, here just focus that night symptoms will be more than 2 per month, and almost daily they will be having symptoms during daytime, and there will be some activity limitation. Then we will consider these individuals as moderate degree of asthma. Severe is symptoms will remain uncontrolled despite the highest level of treatment, and there will be frequent exacerbations. So this is severe. Why we need to divide the disease into such grades is because treatment strategy will differ for each of the class, and whenever we are following up the patient, as mentioned in the earlier slides, we need to step up or step down the therapy based on the changes in these classes. So the treatment strategy for asthma management, mainly in recent GINA guidelines, it has been divided into two tracks. Track 1 will be preferred regimen and track 2 will be the alternative ones. First we will discuss about track 1, that is preferred approach in the management of asthma. And in this approach, the main backbone therapy is combination therapy, that is inhaled corticosteroids and formoterol. So just decide whether your patient is fitting into mild degree of asthma or moderate degree or severe, as discussed in the previous slide. So if the patient is having mild asthma, that is the nighttime symptoms are less than 2 per month, daytime symptoms are less than or equal to 2 days per week, and the individual is able to do usual activities without any limitation. So in this case, we will consider them as mild asthma, where we have to advise them to take this combination therapy only when required. For example, if here is the exacerbation, then we can advise them to take this combination therapy as reliever. So there is no maintenance therapy in step 1 and 2, where we consider the patient as having mild asthma. Whereas in moderate degree, first I will revise what is moderate degree of asthma. A patient who gets symptoms exacerbation during night for more than 2 days per month, and almost daily symptoms will be there, daily symptoms, and there will be slight limitation for the activities. So majority of our patients will be fitting into this category, that is moderate asthma. So here what we have to do for these moderate category patients, MARD therapy is the only solution. MARD therapy, in the sense they have to take this combination inhaler as maintenance therapy every day, and whenever they get exacerbation, during that time again they can utilize the same device for reliever therapy. So daily maintenance will be there, and as required reliever therapy will be there. So step 3 and step 4 are applied like this, but the only difference is the dosage of inhaled corticosteroids, which will change. So first we can try on low dose inhaled corticosteroids. If the symptoms are well controlled, we can maintain on the same therapy. If symptoms are not getting controlled, we can escalate the dose of inhaled corticosteroids to medium dose. Somehow, with whatever dose is required, we have to aim for the prevention of symptoms in these individuals. And if you have started on medium dose inhaled corticosteroids, during follow-up, if you see symptoms are very well controlled for nearly 3 or more than 3 months, then we can step down to low dose inhaled corticosteroids. Hope you have clearly understood about the management of moderate grade asthma. Coming to the severe one, here frequent exacerbations will be there. The patient will require high dose inhaled corticosteroids plus LABA. So this is the therapy for severe cases. The add-on options at each step will be LAMA, tiotropium bromide. We can consider it as add-on therapy. So these are all individualized. There is no clear-cut mark at which we have to start or we have to stop these add-on options. It's not like that. It will all depend on the individual. So you can try these options, and if they are working well, we can continue as add-on therapies. In that, mainly we have LAMA, biologicals. If the symptoms are totally not getting controlled, oral corticosteroids will be the last resort. And track 2, that is alternative pathway, is utilized when there is no availability of formoterol. So if formoterol is not available, we have two options. One is, whenever there is symptom exacerbation, we can take short-acting beta agonist, that is salbutamol. But the point here is, during that time, compulsorily we have to take inhaled corticosteroids along with SABA. Second option will be, inhaled corticosteroid will be utilized as maintenance therapy and SABA is used as reliever therapy. This is second option. Overall point is, never give SABA alone. Whenever you are utilizing this particular drug in the absence of formoterol, always combine it with inhaled corticosteroids. This is the core rule of recent GINA guidelines. And what will be the workflow during acute exacerbations? First thing is, to keep the oxygen level in the target range, that is 94 to 98% with the help of supplemental oxygen. Meanwhile, we can take help of short-acting medications such as salbutamol and ipratropium as nebulization therapy. Then, in the early course itself, we have to utilize systemic steroids, either oral or IV, both are equally efficacious. Even with all these things, if the symptoms are not improving, we can choose IV magnesium sulfate 2 gram, which is infused over 20 minutes and continuously, for example, every 20 minutes, we have to keep on giving SABA nebulization, and if required, we have to take the help of ventilator support as well. And some of the red flags and mortality risk deciding factors are, for example, the risk of mortality will increase if there is previous history of ICU admission or if there is history of SABA overusage, because as mentioned in the first slide, SABA alone will increase the mortality in asthma. And if there is poor adherence to inhaled corticosteroids, mainly apply to moderate and severe asthma category patients, because many of the individuals think that taking maintenance inhaled corticosteroids on daily basis is addictive and it will lead to harmful effect to their health. So this is a misconcept which we have to explain to the patient who are fitting into moderate and severe degree of asthma, because they need this particular agent on daily basis as maintenance agent. And if there are high exacerbation frequency, obviously it will tell that the disease is progressing and it is not getting controlled. And if there are any comorbid psychiatric diseases, that is also a risk factor for mortality. And what are the clinical acute dangerous signs which we have to keep in mind while treating asthma cases is carbon dioxide retention during acute severe asthmas is a critical danger sign indicating impending respiratory failure. This point we have to remember. So whenever we admit acute exacerbation of asthma cases, when we get ABG, our eyes should focus upon carbon dioxide level. If it is high or even normal, the thing is we have to expect lower CO2 in acute exacerbation conditions because of increased respiratory rate. So there should be CO2 washout. If we are seeing a normal or higher carbon dioxide levels, it is a dangerous sign. We have to vigilantly monitor that patient because there are higher chances of respiratory failure. So the overall high-end clinical points are SABA only therapy is fundamentally outdated. Do not use it. Why we are stressing it so much is because even now in India, so many individuals will not have idea about this and they will be regularly using SABA only therapy because it was the most used therapy few years ago. So that point we have to verify and we have to change it. Inhaled corticosteroids must be started immediately, even in mild asthma as mentioned. In such cases, this will act as reliever therapy whenever the symptoms will get worsen. And formoterol is the only long-acting beta agonist which is used as a reliever. That's why it is the mainstay of therapy in MARD, maintenance and reliever therapy. And magnesium sulfate, probably you all might be knowing, is utilized as the next definitive step in management of severe acute asthma. And remember, in acute severe asthma cases, early administration of systemic steroids saves life. This point is very important. Not only utilizing systemic steroids, the timing will also matter. So, early administration is more beneficial. In summary, we can say that there should not be any privilege for SABA alone therapy. ICS should be utilized for all. MART is the best strategy in asthma management. We have to consider step up and step down therapy based on the symptoms control and prevent future risk of exacerbation by regularly assessing the inhaler usage technique, whether the dosage is adequate or not, and any preventable and modifiable risk factors if present, we have to address them as well. So these are the overall points as per the recent GINA guidelines for asthma management. Hope you find it helpful. I hope you got a clear picture for the management of asthma cases. Please share it among your friends and colleagues. See you in next video. Till then, take care. Thank you.